So I resent on that, and I had my reservation. The organizers are not aware of anything, and he's introducing the senior most professor as associate professor. So that's a shameful act. I'm sorry to say. So I don't know whether I'm going to speak good or bad. That's a different issue. But certain facts remain at their own place. So the introduction should be proper. The first slide, please. Bismillahirrahmanirrahim. I begin with the name of Allah, who is the most beneficial, who is the most merciful to the mankind. And I was next, please. I have to control it, and when I fall sick or ill, it's the He, Allah, who heals me. So وَإِذَا مَرِضْتُ فَهُوَ يَشْفِينِ. So I really, this ayah Mubarakah is specifically very, very helpful when we are counseling with the cancer patients specifically, and with patients who have incurable disease. And naturally, some of them, they do get benefit of that. Next, please. Oh, sorry, well, this is my introduction. So now I'm teaching at the university level. It's King Edward Medical University. So I'm sure almost everybody is knowing me. So that was just to remind the organizing faculty that they should introduce the people in a proper way. They didn't ask me for a CV, and I didn't need that in Lahore at least. So now, an approach to the respiratory tract infections. Really, when I was asked to talk about the respiratory tract infections, so I myself was confused. The way I was confused last week I was invited by WHO to speak at Philippine Manila to the TB experts. I was the only speaker from Pakistan. And the topic was very simple. Factors for default in DARS program, tuberculosis control program. And similarly, so although it was a very good presentation ultimately, so again it was a huge task, because there are a lot of infections. If you talk about the infections, the upper respiratory tract, the lower respiratory tract, the concepts of upper respiratory tract and the lower respiratory tract, and you know that the viruses, the bacteria and the fungi, they all infect both the systems. About a few months ago, we have published a case of the fungus in the sinus that was being taken as a malignancy. So it's a huge topic. So if we start talking about the details of a disease, then it will create a lot of problems, and naturally it cannot be covered in such a short period, although we have got 2 lectures. So I think a rational way of talking about these would be that how to reach a diagnosis, how to smell the disease, and then probably we can talk about and we can interact with each other. You can ask me questions, and I can share your knowledge as well. I know I'm not talking to the undergraduate people. You people are learned people. I know all of you. Now, just I'm sure about it. It may be new for some of you. Middle year. Whenever you are going to talk about the infections of the upper respiratory tract, so middle ear is going to be a part of that, being connected to the nasopharynx through the eustachian tube, and commonly involved in the upper respiratory tract infections and even in the lower respiratory tract infections. If you talk about the Mycoplasma pneumoniae, and it's quite a common question, although there are other organisms which also lead to the inflammation of the tympanic membrane. But if someone talks about the findings, the symptomatology relating to the lower respiratory system, with the symptoms just simulating pneumonia, and ask someone, the patient also complains earache. So what's the diagnosis? So naturally it's a part of the respiratory system. The answer is Mycoplasma pneumoniae. So it's the So upper respiratory tract begins. So it's very important. Believe me, honest to God, hardly ever I come across when I ask the people about from where the lower respiratory tract begins. Very, very few doctors, although I know that I have been a teacher in anatomy as well, and they know they have passed their anatomy physiology examinations, but virtually over the time, over the years, they forget. And I do forget so many things, and if I do some mistake, hopefully I will be forgiven for that. So the upper respiratory tract begins from the nose, and then is the nasopharynx, then is the middle ear, and then is the larynx. And then the lower respiratory tract. Now, important, from where the lower respiratory tract begins. A common answer to that question is always, some doctors will tell me the carina, the other will tell me the terminal bronchioles. Very few, occasionally, and if someone knows that in that batch who is working with me, specifically the newcomers, house officers, so he himself will be confused anyway, because the others are telling that way. So the lower respiratory tract begins with the beginning of the trachea. एक्चुअली मैं आपसे जो बात कर रहा हूँ, मैं अपने एक्सपीरियंस के बेस पर कुछ कॉन्सेप्ट्स क्लियर हो जाएं. ज़रूरी नहीं कि सभी के गलत हैं, सभी के ठीक हों, बट वी कैन टॉक अबाउट दैट. सो द लोअर रेस्पिरेटरी ट्रैक्ट बिगिंस विद द बिगिनिंग ऑफ द ट्रेकिया at the start, the junction of the larynx, cricoid cartilage. So that is the junction. So there it begins, and then we all know that it is the trachea that bifurcates at the carina into the both main bronchi, right and left, and it goes up to the terminal bronchioles. So what is lung parenchyma? We'll be talking about that. So the concept should be clear. The diseases are of the upper airways, the diseases are of the lower airways, and the diseases are of the lung parenchyma. So lung parenchyma, these are the structures distal to the terminal bronchioles. Now the structures distal to the terminal bronchioles are these, again, up to this level. So up to terminal bronchioles are the airways. After that is the lung parenchyma. These are the respiratory bronchioles, alveolar ducts, atria, alveolar sacs, and alveoli. ये सारी स्लाइड्स मैंने अपने हाथों से बनाई हैं, कोई बारो नहीं की, और मेरे बनाने वाला बंदा भी नहीं था, मुझे 2 दिन टाइप करते हुए लग गए. Now this I have taken from Guyton's Physiology. Unluckily I had a Pakistani edition, otherwise it's the colored photograph in the original book. So this depicts the lung parenchyma. We call it as acinus as well. So this is you can read that this is the terminal bronchiole ending up, this is the respiratory bronchiole, these are the alveolar ducts, these all that are alveolar ducts, and these are the atria. And then alveolar sacs originating from everywhere, from here as well. So actually the exchange of gases takes place from this area to all that. So now our concepts are clear about the upper respiratory tract and the lower respiratory tract and the lung parenchyma. I think by this time we should be clear about that. Now history is really very important. Of course everything is important whenever we are going to examine a patient and naturally going to make some diagnosis and manage that. So but the cardinal manifestations, that is if you are insulted the way I reacted, so how you are going to react. So if the respiratory system, upper respiratory tract is, although the cardinal manifestation which I have written are not written anywhere, I just thought probably they are more important for that. Otherwise, whenever you go to some clinical methods, to some other medicine book and all that, whenever there is an introduction of that system, there is always written for the cardinal manifestations. And for the cardinal manifestations of the respiratory system, when they talk about the lower respiratory tract, I'll be coming up, that is written everywhere. So I thought that probably nasal obstruction, because we are talking about the nose, nasal discharge, that may be in front, and the postnasal discharge, and that may be watery, muc and all that, and pussy as well, and at times the patients complain with epistaxis, and so if there is a pharyngitis or tonsillitis, so there is a pain in the throat and hoarseness of voice, when the vocal cords are involved or the larynx is involved. So that's anyway. Just we talk about the hoarseness of voice. You see viral laryngitis, tuberculosis laryngitis, or bacterial laryngitis, but tuberculosis is the bacterial laryngitis. So there is hoarseness, and then there are other problems like growth, polyp. There is hoarseness. So the behavior is similar, the hoarseness of the voice, because of different inserts to the larynx. Now, respiratory tract is all the time is exposed to the environment. Naturally, for that reason, so it is all the time confronted with the environmental hazards. So anything is the surface area, the capillary surface area of the lungs is around 500 square meters. So you can well imagine. So how far the irritants, the bacteria, the dust, everything is going, and you can well imagine. So such a huge area, and then God has gifted, protected his creatures, and also the respiratory system. We all know about the defense mechanisms which keep us healthy. So if you talk about the upper respiratory tract, so the nasal hair, the ciliated epithelium, the sneezing, all that, all the way. And specifically the presence of IgA antibodies. Normally the airways below the vocal cords, they are sterile. And anything which tries to enter into those, to the lower respiratory tract, so that is expelled out with the cough reflex. And then there are other mechanisms for protection, that is the presence of the IgA antibody. You can remember IgA antibodies to the epithelial linings. In the GIT it is IgA. Whereas in the blood for others, you know that the first antibody which comes for to combat the infection, can anybody tell me? First antibody pathologist is sitting, he can tell. IgM. Then IgG is naturally, and IgE and D and all that. So IgM and IgG are the main, and IgA for all the endothelial linings and all that. So they are defense, and then the general defense mechanism, alveolar macrophages are there to defend that. So spectrum of microorganisms is towards increase. So when they are towards increase, so there's going to be more insult to the airways anyway. And there is a huge spectrum for gram-positive, for gram-negative, for atypical, for mycobacteria, for atypical mycobacteria, and then fungi. So they all are invading, and naturally, so you have in any way to be protected from those. And most infections cannot be prevented, like viral infections. How you can prevent? There's nothing you can prevent. Even for tuberculosis, you can take certain measures. So what are the objective of their management? As far as the upper respiratory tract infections are concerned, so possibly I feel it's very rare that the death will occur. But in the lower respiratory tract, they are quite harmful in any way. If you talk about pneumonia, the fungal infections of the lung, for tuberculosis, for atypical tuberculosis, and many others, so they lead to death. So naturally, the objective is to prevent death and minimize morbidity. So that is the objective of when you are dealing with the respiratory tract infections. Now, I prepared only very few slides. Viral rhinitis, I didn't need that. Everybody is aware about the viral rhinitis. So, but this is the commonest disease of the respiratory tract, including both upper and lower respiratory tracts. But in testing, 1977, I can go back. There was naturally the things go on changing, the etiology, the pathogens, the other things, the new bugs come in, the olders go away. So it was, at that time, the golden chess book, Hinshaw, no more in the market, 83, that was the last edition, Hinshaw and Murray. So there is a lot of discussion about that, and that was the commonest disease coming to. You may be knowing better than me what type of disease you encounter in Pakistan, in your private clinics as family physicians. Although I understand in this weather, probably you will be getting more gastroenteritis. and in winter maybe more respiratory tract infections, upper and lower. Am I right? So because our environment, but the temperature, the climate in other countries, although in America all sort of climates are there, but talking about Europe and others, so the heart virus is not that much hot. The respiratory tract infections are the commonest with the family physician, and about 90% of them are possibly coming in routine or from the respiratory tract, and again that split that was the older one, so 90% of them are viral. And the sentence written was that how shameful it is that we go on prescribing antibiotics to these patients. So that is about the American society, American rule. So so we all know that's a malice. So at times it may be depending upon the virus. There's a long list of the rhinoviruses, influenza viruses, parainfluenza viruses, and adenoviruses, and echo, but a lot of viruses, respiratory syncytial virus, all that, and specifically it may be dangerous at times, even the viral infections like influenza infection when it leads to the pneumonia and other complications. So the headache, nasal congestion, whitey rhinorrhea, sneezing, and a scratchy throat, malaise, nasal mucosa is red, edematous, and whitey discharge. So naturally, you don't need any investigation. Just even the patients may not come to you in the community. Some people, they have got that certain ideas. You may be coming across those. Although we all, so there is a lot of nowadays hue and cry that there should be community-oriented medical education, and I attended a workshop for that, abbreviated as COME, and they say that the people should go, the students should be sent to the community, and there they should be taught, they should, in the real scenario, they see the patients, the people, and they come across. But I think the scenarios are different. You can't deny that defense is not a community, or Gulbarga is not a community, or Basti Sadan Shah is not a community, but the communities are different. So the spectrum of the disease is also different. So in a richer community, hypertension, diabetes, and others, and the poor, the infections. So आप इमेजिन करेंगे, मैं लोगों से मिला हूँ, वो कहते हैं जी खट्टी लस्सी पी लें तो नज़ला ठीक हो जाता है, ठीक है. तो इसी तरह तो आपको भी पता है कि सिम्टोमेटिक ट्रीटमेंट है, तो इसमें और भी बहुत सारे लोगों के मिस होंगे. सो इट्स सिम्टोमेटिक एंड सूडोएफिड्रिन may relieve the symptoms plus analgesics, antipyretics, and important thing is hold the antibiotics, resist to prescribe antibiotics. So when to prescribe antibiotics? Usually if either it is going to self-terminate within a week or so, but if it's not, if the secretions become purulent, so then you have to intervene. Naturally, then some infection, bacterial infection has been super added, so that is the time to prescribe the antibiotics. Or if you want to give some antibiotics, so they should be prescribed after 3 or 4 days after the start of that, when we are expecting that now at that time the super added infection may be there. So pseudoephedrine for opening up and other things, you know better than me this condition. Now, a lot of material in this slide, because even I didn't want to prepare this slide about sinusitis. Now, sinusitis is the inflammation of the sinus. We all know that the sinuses, they give character to the voice which we speak about, that the resonance to that is imparted by the sinuses, and we all know that they are the frontal sinuses, ethmoidal sinuses, and the maxillary sinuses. Now the frontal sinuses and the ethmoidal sinuses, mostly they have no problem because their drainage is downwards, although they do get infected if it's a viral or something like that, but usually their drainage is dependent downwards. But the problem with the maxillary sinus is that they are situated in the maxilla, and whereas their openings are superiorly located near the inferior turbinate, so they are not in, they are in the dependent shape. So if their ostomy is closed, so the secretions get blocked, and naturally they are going to get infected. And then initially we know that of shorter duration acute sinusitis and of chronic duration, so the chronic sinusitis. And chronic sinusitis is a huge problem socially as well. So you can well imagine acute sinusitis. This is I have taken this material from Current Medicine, and this is also there. This is also there in other chest medicine books, that $2 billion per annum expenses for the management of acute sinusitis in US. You can well imagine. This is correct. $2 billion in America, 52 countries, not a single country, 52 states, we know. And common pathogens, now this you have to remember, these common pathogens are shared by the middle ear as well, and other areas for the epiglottis, and we'll be talking about that, and for the tonsils. So we know Streptococcus pyogenes. So these are the common organisms for all these which lead to the infection. When it is bacterial, we have talked about the viruses, they are going to the same. So Streptococcus pneumoniae and other streptococci, Haemophilus influenzae, these are the common ones. Streptococcus pneumoniae is the commonest one. Then Haemophilus influenzae, and less commonly Staphylococcus aureus and Moraxella catarrhalis. And pain and pressure over the cheek is the common symptom with the nasal blockage, with the postnasal discharge, and specifically, and at times the patient are just used to that. Although when it's acutely there's going to be headache, there may be toothache, specifically with the upper incisors and the canines. So that is the area which is shared by the trigeminal nerve, passing through that into the going to line that the maxillary sinus, and nasal congestion, pussy discharge, and post-nasal symptoms are troublesome. And some 5-6 years ago, I diagnosed a girl who was having a chronic cough, very severe cough at night, and almost she had consulted 50% of law. And just when I went for a XHS, there was chronic sinusitis. And once the infection in the sinus is there, it's really difficult. So the rule applies always the rule applies that wherever there is the pus, that has to be trained. So it is the job of the ENT, a person trained in with the ENT specialty or some consultant in that, so who have to wash the senses and all that, they open up, that is a very minor surgical procedure done on the basis of the outpatient department. And so the sinuses are washed. Although there are surgical intervention, Cardwell lax operation, if there are certain complications in that, some growth, some papilloma, something like that is there, we all know about that. But naturally, we as family physicians are concerned to alleviate the symptoms, to give certain decongestants. You may be knowing better than those xylometazoline, therapies and all that for this, and we all know that they should not be used for a prolonged period. So because ultimately there's going to be rebound congestion, and which is going to rather put the patient in more difficulty. So, and antibiotics which cover at least these. So specifically, so if you're talking about the Haemophilus influenzae, so if I have to talk about that, then I will go to the second generation cephalosporins like cefluroxime or the other ones similar to that, or one of the fluorinated quinolones. You all know about levofloxacin is nowadays commonly is very much there and is going to cover a lot of pathogens, including atypicals as well. And then sparfloxacin is also there now. Its Me Too are available in the market, and moxifloxacin, although costly. So they are really effective, and at times a combination of a macrolide and aminoclavulanic acid are a second generation cephalosporin. So it's the same regimen which we prescribe for the lower respiratory tract, specifically in the community acquired pneumonia. So they are effective. So in one slide, I have covered the upper respiratory tract in this. We all know about the pharyngitis. Naturally, I'm talking to my senior colleagues who know a lot about that, pharyngitis, how it presents. The pathogens are the same. Either it's going to be the viral or it's going to be bacteria. And again, there is going to be sore throat, and depending upon there may be, now here when it comes to there is the pain on dilatation, ondynia. The word used for that is the ondynia. And then if it's severe and involves the tonsils, leads to the tonsillitis, and the pain is going to be severe. Temperature is specifically when it's a bacterial one, is very high. And although I don't practice in the pediatrics, but I am sure about that in pediatrics, it may be a crime if some child comes with symptoms with high-grade fever and there are no localizing symptoms. So just to omit the examination of the throat. So one should have to look into the tonsils. So quite often you will come across the disease, the bugs over there, the inflamed, angry-looking tonsils and all that. So that examination should never be omitted, both in adults and in pediatric practice. So naturally there is a fever, there is a pain and all that, and the patient presents that way. You examine it, and then you have to prescribe the antibiotics. Some 30 years ago, the Americans, what will they do? Only give Panadol, long-acting benzathine, penicillin for this tonsillitis. Streptococcus pyogenes is the commonest organism, and still that holds true. The people over there are afraid of. Just one injection of benzathine penicillin in tonsillitis suffices the treatment. But you can give the penicillin B as well, and amoxicillin and augmentin, and the way you like. And only rarely 10% resistance is shown by WHO in Pakistan to penicillin, to Streptococcus pyogenes. So if you are looking for that, you may go for some macrolide, maybe a dual macrolides, and specifically with the comfort, that is the azithromycin, probably with tissue deposition, all claims, and certain Americans, they like to prescribe azithromycin for that, 500 milligram for 3 days. Peritonsil abscess, what is called is in the ENT is an emergency. There's an abscess, and the patient is having high-grade fever, and this is the extension of the tonsillitis. It's a complication of that. And interestingly, so although I have not made a full slides, but I have gone through that, the whole what could I see in 3-4 books. So interestingly, the tonsillectomy is not recommended. Very little recommended. That should be kept in mind. Tonsillectomy is not recommended anyway, except when there's a lot of problems. Normally, with the minor difficulties and all that, are only one indicator. If there are really chronic attacks, repeated attacks of that, or if there is some asymmetry in the two tonsils, and the possibility in that one, which is a larger one, is that it may be harboring a lymphoma, like Hodgkin disease and all that, then it is recommended that tonsillectomy and histopathology should be done. And it's not that should be then thrown away. Then it needs any tissue which is removed, that needs histopathological diagnosis. Epiglottitis, specifically in children, is really emergency, and it may obstruct the airway, and the patient, if really early intervention is not done, the infant or the child may die, and almost always this is bacterial. Epiglottitis is bacterial, and quite often it is going to be staphylococcal infection or some other organism for which you have to give good antibiotic cover. And again, I would say that the one which we give in pneumonia, aminoclavulanic acid, amoxicillin, along with macrolide, or at times this third generation cephalosporin, you may need, and all that. Laryngitis, again, viral laryngitis, we all know. I'll be talking about that, giving a touch to that. I have decided to talk about, because mainly I'll be focusing on the approach to the respiratory tract infections. I'm not going in detail. I can answer your questions, queries, but how the patients present, how you are going to interpret those, as the topic was. So coming to the laryngitis, it's going to be viral. So we all know. So when it's a viral laryngitis, so it's the cough, the loudness to the cough is important. The hoarseness is there, the loudness is there, and there may be pain at the site of that, which can be localized to that area. So, and the character of the cough is, we call it barking cough. Very loud cough, and the name given to that is barking cough. And we know that and the treatment is again symptomatic, and specifically when it is tuberculous laryngitis, this is highly infectious. When tuberculous laryngitis is there, quite often it's a complication of the advanced pulmonary tuberculosis, where there is a lot of cavitation and the tubercle bacilli are being excreted in the sputum, and they invade the larynx, and this tuberculous laryngitis is really highly infectious. So you have to go for again the same test for sputum for ARB for 3 days, and naturally the treatment, once the diagnosis is made, is the same for tuberculosis anywhere in the body. The regimen is the same. जब आपने ब्रेक करना होगा मुझे बता देना, मैं तो 2 घंटे भी बोल जाऊँगा. ये आपने बताना है मुझे कि कब आप रुक जाए, हमने चाय पीनी है. अब क्या है? Now spending some time on the patient is really very important. I'll be talking about that, and this history taking is more important than physical examination. Like that COPD and asthma. Now in asthma and COPD we all know that the presentation may be absolutely the same. The patient is breathless, it's dyspneic, and when you examine the patient, the expiration is prolonged. Of course, it's the labored breathing, and there are bronchi. They may be both in the inspiration and in the expiration. Then how to differentiate between these? And if you say that there is a sputum production, there is infection in COPD, that may be in asthmatics as well. Specifically, the smokers may be presenting smoker asthmatics, where the superimposed COPD may be there, or asthmatics may be having now some respiratory tract infection. So it is the history, because we know that the history of asthma is entirely different. It is an episodic history. The disease comes in the episodes, and in between that the patient may be free of symptoms. There may be family history of asthma or some certain other allergies. So the history is really very important. And quite often in the in our public setting, what happens is the doctor is busy and just he will put up the X-ray chest and may listen to the patient or may not listen to the patient, and may write down certain prescription and just dispose of the patient without auscultating the chest. So the auscultation of the chest is a must. Because we know that normally early COPD is not going to give any sort of abnormal shadowing on the X-ray chest, and similar is the case for asthma. Although during the attack there are certain changes, but only a vigilant person can judge them, and naturally even then one can't make the diagnosis. So the cardinal manifestations of respiratory system is the cough. Certain diseases can only be if you know that. So cough, sputum, chest pain, hemoptysis, dyspnea, and wheeze. I'll take them one by one. Now cough is the commonest symptom. Its frequency, severity, and character depends upon the situation and nature of the lesion, presence or absence of the sputum, whether it is dry or wet, coexisting abnormalities, that is vocal cord paralysis. So pleural pain, so naturally if there is a pleural pain, the patient will try to suppress the cough even if there is a lot of irritation and all that. And you have to know where are the cough receptors. You can well imagine the cough receptors are in the pharynx, in the larynx, in the airways. They are very much there, but they are in the diaphragms, and they may be in the stomach, and they are in the tympanic membrane. And they are in the pleura. So when you are taking out the fluid from the pleura during chest aspiration, the patient starts coughing because the cough receptors are there, they get irritated, and which may be something very dangerous at that time. if you don't take out your needle, so the patient can develop iatrogenic pneumothorax. So it's really very important. And vocal cord paralysis, if that is there, so what is going to be the character of the cough? Anybody who can tell me if there's a paralysis? आप लोग प्रैक्टिस तो करते हैं ना? Anybody? Volunteer? The voice is not there. So it's a pharynx. When the cough is because of the irritation in the pharynx, it is very much localized to the pharynx. Irritation is localized to that, and one is coughing, and one can always localize to that. It is a non-specific cough. Nothing. It is no special character. Whereas in case of larynx, so usually if it is a laryngitis, somewhat pain is there, and when it is a laryngitis, we have already talked about it's a harsh barking quality, barking cough. And when it is the paralysis, it is going to be the bovine cough. Has anybody heard the bovine coughing? किसी ने नहीं बताया? तो कैसे कफ करते हैं? आपने हाथ खड़ा कर दिया. It's very simple. I can do it on the. I can simulate it for him. So there is no character to that. So like bovine cough, वो गैसों वाली नहीं, which you see on the television, is the barking cough and the whooping cough. Although under the EPI program and in the people are getting the vaccination, the children are getting the vaccination for the whooping cough, and I am sure that the parents are getting this whooping cough. Let me finish this slide. So, the whooping cough. So can anybody? So, will you believe me? I see 10 to 15 patients in a month of whooping cough in adults. So the whooping cough, if you go and see, आपको जो मिलेगी नहीं. The whooping cough की description in adults is only given in Harrison's Principles of Internal Medicine. Harrison, if you want to read that, but if you can listen today and you can go and treat, you don't need to read that. So it's again episodic paroxysmal cough, very severe nature, and specifically, so there is an overlap. So technically, it is very difficult to the serological tests only can tell you about the diagnosis, which are not available in Pakistan, but it's always a clinical diagnosis, and there's a lot of overlap. They may be there. डॉक्टर साहब हंस रहे हैं, वैसे कर रहे होंगे कुछ शायद. तो आप करते हैं कुछ पैथोलॉजी है ना आपकी? तो डॉक्टर सरवर मुझे आपके साथ मुझे नाम भूल जाए. डॉक्टर साहब का नाम सरवर नहीं है? क्या नाम है इनका? आपका नाम मैं भूल जाता हूँ मैं, बट आई मीट हिम एवरीवेयर. मुझे नॉमिनल डिस्फेजिया, ये भी हर्सन ने लिखी हुई है. Nominal dysphasia, aphasias, and there are certain people have got certain problems. When they forget the names, it's nominal dysphasia. So I'm sorry for that. मेरा ख्याल था डॉक्टर साहब पैथोलॉजी. तो इस whooping cough is just a patient breathes in and the expiration is prolonged and is interrupted, and at the end. So I see a lot of cases. If the patient coughs in front of me, I usually make the diagnosis. And the Chinese call it 100 days cough. और हमारे हकीम साहब जो बचपन से मैं सुनता आ रहा हूँ कि 40 दिन की खांसी है, ना 4 महीने की खांसी है. So 4 months cough. So naturally, and once it is established, up till now on the earth, there is no remedy for that where you can get rid of that. Only steroids work. Along with macrolides. Whatever I talk to my patients is that you can be only helped in that way, that we can cut down the frequency of attacks, the duration of the attacks, and the severity of the attacks. But it cannot be told to you that for how long they are going to persist, but not beyond 4 months. So that is it's a huge and very severe. Even I had seen the cases, although they are, I think patient is the best guide, with subconjunctival hemorrhages, such a severe cough. Now one of my patients has recovered, has fracture of the rib just because of the coughing coming from Mandi Bahauddin, very severe, and they were roaming about that, and I told them you have got a fracture, and it was a micro fracture which was proved on this bone scan, which they themselves went for that, and it was very much there. So it's very severe. And you know about that the cough syncope? Although it's not for the cough syncope, is again one of the presentations of the whooping cough. The patient coughs so much that the patient becomes unconscious, and that is called cough syncope. So stridor, I've talked about doing inspiration. That is because of in children. In adults, when you come across the whooping cough, in adults the voice box, the larynx is of larger size, whereas in case of children it's the smaller size. In children it goes into spasm, and when it is narrowed, so there is a stridor. Stridor is inspiratory noise, and that can be produced either the narrowing of it can be of the trachea as well, and it's that way of the whooping cough. It may be due to the this foreign body inhalation as well, if that gets impacted over there, and then stridor becomes a variable and fixed one. When the foreign body gets fixed over there, so it's always there when it's because of the other disease like whooping cough, so it may vary. Like diphtheria that gives through, although it's not that common nowadays, so because of that vaccination, so it's so I think I finish over here. If you want to ask certain questions up till now, so it's better to finish. Actually, I didn't present that material, and neither I projected that, or nor I use that in that. So if you need, your coordinator told me that as a shortcut, I can go to the internet and can download the material for your teaching for these lectures. So I did download if you need that. So you can get it from my computer, from my laptop that is there. But I didn't know that how to use that. You can read that, but for reading that's good. For projection, it was not possible to include that in my presentation.
You can have handouts of that.
Now, if you allow me, should we start it now? Now, well, we were talking about the history, the cardinal manifestations, and my main concern is about the infections of the respiratory tract, because there are other diseases as well where the patient is going to present with all these cardinal manifestations, but I will try to avoid to touch those aspects in my presentation. Now, trachea and bronchi. Now, there are no boundaries, anatomical boundaries in the upper and the lower respiratory tract which participate. So any infection in the upper airways naturally descends to the lower airways, and the concept of ARIA, allergic rhinitis implicated asthma, just has taken origin from there, that the anatomically upper and lower respiratory tract, they share certain similar things, and certain insults are similar, like the inflammation which takes place in the airways in asthma. Similarly, when there is inflammation of the trachea, acute tracheitis, it is not simply acute tracheitis, it turns to be acute tracheobronchitis. So, and then what happens in cough is there is this retrosternal pain along with cough, and there may be sputum and in acute phase which comes loosely, although that is not in larger amounts, and that finishes acute bronchitis. That is, we are talking about the cough, and specifically the history of the chronic bronchitis is really very important. Very important. The patient always comes and tells doctor, well, I smoke, just because that smoking brings up the phlegm that initiates cough, and I can bring out my sputum anyway. Anyway, can anybody tell me about what is sputum? I'm talking again and again. Anybody open, because you are going to appear, I think so, after that. Do you intend to, is there going to be some examination for your fellowship? Anybody? I'm talking about the concepts. Well, anybody else would like to add up anything?
The secretions due to the information of
we'll be talking about that. You can think about, we'll be touching that after this sputum. Now, chronic bronchitis, that is the history to begin with. The smokers, what happens? This sort of statement is true on getting up in the morning, and during the daytime, they are totally free, and when they are going to retire on the bed, so the similar symptoms appear, that they cough and they bring out the phlegm, small amounts of the mucoid sputum, and after that their chest is free and they continue smoking. So we'll be talking about that. The clinical definition of the chronic bronchitis is the presence of cough with expectoration for at least 3 months in 2 consecutive years. So 3 months in each year for 2 consecutive years almost. So that is the definition of the chronic bronchitis, and that cough goes on increasing and the sputum goes on increasing, and we're not talking about the chronic bronchitis, just the complication. The commonest presentations of the respiratory tract, my slide will project, which presented in the hospital practice, are acute exacerbations of chronic bronchitis and pneumonia. The two commonest respiratory tract infections, the people who need hospital treatment. So naturally, before reaching the hospital, they come to the family physicians. So I'm sure you see much more cases than we people. So I'll be talking about that acute exacerbations of COPD later. And then bronchiectasis is the abnormal, persistent bronchodilation of 2 millimeter size and more. So it's almost permanent, and the respiratory epithelium is damaged, and because of that, the defense mechanism, the clearance mechanism, that goes away, and the secretions they pool down in that area, they get infected, and there is sputum production, and naturally, so a lot of sputum is there, and specifically when there is anaerobic infection, so it is putrid as well. And similar is the case of lung abscess. So lung abscess is a chronic indolent infection. It may be of acute onset when it is because of the necrotizing pneumonia, like gram-negative pneumonia, pseudomonas, or Klebsiella, or staphylococcal infection. But most of the time, traditionally, when you talk about the lung abscess, then you mean normally the anaerobic infection, anaerobes, which are normally present in the mouth flora and are aspirated during the sleep or during some dental manipulation in the dental chair, and they lead to the formation of the lung abscess. And there are copious amounts of the sputum along with ill health and all that, and lot of foul smell is there, lot of foul smell. From the foul smell, so again, we're talking about the upper respiratory. Anybody who can tell me about ozina, just to keep you, say attentive to this. Ozina. No, nobody would like to. So, what is halitosis? Halitosis is actually the foul smell in the breath. Halitosis is foul smell, and ozina is atrophic rhinitis. It is extremely foul smelling condition. Can you imagine that Islam mein 1400 साल पहले इसके बारे में जिक्र आ गया, अगर आपने पढ़ा होता तो उसमें ये है कि खातून जो है खुला ले सकती, खुला को बुरा समझा गया इस्लाम में, लेकिन इस एक कंडीशन पर अगर हस्बैंड को जीना है तो वो खुला ले सकती है। तो it's very difficult to bear the person and vice versa. So the pneumonia, again no special character of the cough. Initially it is dry, and then ultimately it becomes wet when in the stage of resolution, and then pulmonary edema is just to fill that. It's an entirely different situation. I'm talking about the respiratory tract infections and fibrosing alveolitis. So it's complicated by although in fibrosing alveolitis now it is not an uncommon disease. About 10-15 years ago it was an uncommon disease. Just I want to touch it over here that we may not come across again, that in fibrosing alveolitis, although when you talk about if you say it like that, diffuse parenchymal lung disease is the other new name for that, interstitial lung disease, and so the birds have got hypersensitivity pneumonitis. In Pakistan they have got a lot of role, the bajigar, the parakeets, the parrots, the pigeons. I had a paper presentation, and almost everybody has a history of keeping that, and once the disease starts, the ongoing process is difficult to stop, and the patient dies in a very short span of time. Now sputum. Sputum is the expectoration. It is the expectoration of the secretions of the lower respiratory tract. So the technical definition is the expectoration of the secretions of, bringing up the secretions of lower respiratory tract. Now that's really very important. The secretions from the pharynx, and important thing in your family medicine practices, that a patient comes, that he says, you ask about whenever the sputum is there, there has to be cough, because that has to be brought up from the lower respiratory tract. So that has to be cuffed up. Only through the cuff that can come up. The patients come, Doctor Sahab, मुझे बलगम आ रही है, हाँ जी खांसी कितनी, खांसी नहीं आ रही. So what's the reason for that? When they say that, there is a difference between balgam, sputum and saliva. Saliva, that is the secretion of the salivary glands. So anybody would like to throw some light on this issue? I'm giving you very practical tips for your practice. I'm touching. So it's a very the patient comes and tells you that he is having lot of sputum, balgam. And when you ask what about the cough, he says there's no cough.
Because cough is due to irritation, and when there is a lot of damage, there is only sputum and there is no separate.
But again, there is going to be cough, and I do agree if there is some postural change, specifically if the basal segments are involved in bronchiectasis and lung abscess, if one goes for going for prayer, or there is a change in the posture, the patient will bring up a lot of sputum. There's going to be, and again it is going to be followed or accompanied with cough. But always you will have to demonstrate, you will ask, it is 99% of the time the secretions of the sinuses, it is the post-nasal discharge, and you ask, you do it, you suck it back so naturally, and then you throw it out, so the patient will say yes. So it is the chronic sinusitis. So you have to be vigilant about that. Any patient, I had seen many patients coming telling that they are having sputum, and when you go for that and you ask for the history of the cough, that is not there. So if that is not there, then you have to ask the patient whether you suck it back and then you throw it, the patient will come up, yes, that is there. So that history is really very important while going for physical examination is there. So you ask about the amount, the color, the character. So we have talked about the taste or the odor, foul smell and all that, and viscosity initially very viscous and all that. I think in Klebsiella pneumonia infection it is very viscous, ropey, tarry, very difficult to get rid of from the mouth. So it's so much tarry. So the patient has to remove it with the fingertips and all that. And then amount is large in case of bronchiectasis and lung abscess. And what is hemopsis? Blood in the sputum. So again, what is so actually hemopsis is the expectoration of the blood from the lower respiratory tract. Hemopsis is the expectoration of the blood from the lower respiratory tract, and the commonest cause for hemopsis in the Western world is chronic bronchitis and bronchiectasis. But in our community, it is tuberculosis. It is tuberculosis, and every hemopsis is not tuberculosis. And always try to remember mitral stenosis. I had seen many cases of mitral stenosis being treated for tuberculosis. Nowadays, I think that the number of cases have lessened because of the availability of the echocardiography. So, because that is a very accurate method of diagnosing that. So one should think about that, this mitral stenosis that can be diagnosed clinically as well as radiologically. So it is the expectoration of the blood from the lower respiratory tract and bleeding from the upper respiratory tract, that is epistaxis, and bleeding from the pharynx and from the larynx. CA larynx can bleed heavily. I had seen cases, but that is not hemopsis by definition. It is a lower respiratory tract. Now that's really very important. And the other important thing about hemopsis is when you are taking the history, you have to differentiate it from hematemesis. So that is really very important. Hematemesis has to be differentiated from hemopsis. In the total clinical career, I had seen definitely one and probably two cases where it was difficult to differentiate between hematemesis and hemopsis. Now actually patient always, very few patient will tell you, in case of hemopsis the blood is always coughed up, but the patient comes to you in our community, says, "Sir, I vomit the blood." So vomiting of blood means nothing. You are really standing and thinking about that. So when you say vomiting, it means coming from the GIT. So you have to differentiate whether it is really vomited. Is there any preceding nausea? Is there any food particles in that? Or there is no nausea, no food particles? Any previous history of dyspepsia that will lead to the direct to the acid peptic disease? Or other features of chronic liver disease, which is a cause for the color, the coffee ground color, whereas in case of hematemesis, and it is bright red color in case of hemopsis. And the food particles, maybe they are in case of hematemesis, whereas they are not there. And then frothy air bubbles are there if you examine that, and very fresh red, and they are not there. So actually on the history, and even if you are in doubt, if you know that even the X is not there, you can differentiate. Put a nasogastric tube into the stomach, aspirate, no blood, keep it there for 4 or 5 hours, no blood, it's hemopsis. And of course X-ray test and other things are going to help anyway. So as again you have I think read about this, the other causes for that anyway. Now chest pain, I have talked about the chest pain of the tracheitis, retrosternal pain associated with the lesions of the mediastinum. I will not touch the pain of the angina pectoris, myocardial infarction. You all know all that about the pericarditis is also the similar pain with the same distribution. And dyspnea. So only one tip. What's dyspnea? Is the sense of breathlessness for a desired level of activity. Now this definition, if you want to write down it, you will not come across commonly. It is a sense of breathlessness for a desired level of activity. So if a person with sedentary habits, so the example for that is becomes dyspneic after running 100 yards, it's not significant, but it is significant if a marathon racer becomes now dyspneic after running 10 miles because his level is 25 or 26 miles. So it's a sense of breathlessness, it's something relative for a desired level of activity. Now two things are important. Although there are many reasons for dyspnea, it may be of psychogenic, that has to be at the last. But it can be either because of cardiovascular system or because of the respiratory system. Simple